Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elsiegood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose Naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. Jersey Shore Pharmacy is a fully licensed and accredited pharmacy in New Jersey, specialising in compounding formulations such as LDN, bioidentical hormone creams, omeprazole and pet medications. They strive to help everyone with their individual needs. Visit www.jerseyshore.pharmacy or call 609 660 1111, Monday to Friday 9am till 7pm, Saturdays 9am till 3pm. You can find them on Facebook. Today I'd like to welcome my guest, pharmacist Dr. Eric Borgeson from Jersey Shore Pharmacy in New Jersey. Thank you for joining us today, Eric.
Well, thank you for having me today.
Could you tell us how you got into pharmacy?
I originally got into pharmacy when I was 15 years old. I got a flyer in the mail, and it was about a Lamborghini, and I wanted to drive a Lamborghini and own one. So I got into pharmacy because there was 3 ways to get the money required to buy the Lamborghini. It was either to inherit it, which wasn't most likely going to happen, 2, win the lottery, which did not happen, and the third way was to cure a disease. And then while in college, getting closer and closer to a degree in pharmacy, you become, your ideals change and your goals change. So I became more of a person who wanted to help people and to help take care of other people and help them with their medications and getting better and staying well than it was about a sports car.
Mm-hmm. And have you thought any more about, curing a disease?
Not so much. I mean, curing a disease seems almost impossible at sometimes to say, like, to be able to come down to the exact smallest things that actually cause the diseases. Like, it's easy with something like with HIV or AIDS, where it's a virus, and you just have to figure out how to stop the virus and stop it from replicating, versus like a bigger disease such as like a cancer or like an MS or Crohn's, when there's so many factors that go into it that you don't, to stop one factor is great, but then it's still there and still happens, and we still don't have you, scratching your head as to why is this still occurring. Like, I thought we stopped it at the source.
Yeah. Okay. So in your pharmacy, what do you mainly do?
We mainly make hormone replacement therapies that involve progesterone, testosterone, estriol, estradiol, and that. We also make supplements for various ailments that people have, and then other various ways that people wish to stay well. We also do the low-dose Naltrexone for fibromyalgia, our patients who have fibromyalgia. We also have patients who have MS that get it, and chronic fatigue syndrome that we seem to help out with that.
Mm-hmm. Do you have many doctors
Those are
that?
3.
Do you have many doctors that are prescribing?
It takes a special kind of doctor to prescribe it, it seems, like one that believes in trying a different approach or what their patients bring to them to try. So we have a lot of we have about a half dozen neurologists that do prescribe it in the area, a few alternative practice doctors that prescribe it in the area, but we don't have really any gastroenterologists who prescribe it much.
Oh, okay. And I always find that the most prolific prescribers are mainly nurse practitioners. Do you have many of those in your area or none at all?
We do have a lot of those in our area, a lot of physician assistants and a lot of nurse practitioners, but they don't seem to really do a lot of the alternative medicines in the sense of the low-dose Naltrexone. tell their patients that way. They seem to stay more towards the Western medicine ideals of this is what the book says, this is how I treat my patient for X, Y, Z.
Well, we did 3 talks last year in actually a bit like a roadshow, taking LDN out there and getting pharmacies and prescribers in the area invited to come to an evening, just a 2-hour talk on LDN. That has been really successful. So maybe we need to come to your area and get your prescribers to come along and listen, if they will listen.
That sounds like an excellent idea.
Yeah, that definitely does, doesn't it? So what forms do you compound LDN in?
Primarily, we make capsule forms. We made liquid for one person before, but primarily we just make LDN capsules. There was a prescriber, there was a psychiatrist who had interest in a low-dose naltrexone cream, but he never either followed through with it or never found a need for it.
Oh, that was a shame. I mean, it seems to be working extremely well for mental health issues and also with pain. Even people that are taking high doses of opioids by using ultra-low dose naltrexone. Do you have any pain specialists in your area?
We do have a large amount of pain specialists in our area, but none of them have prescribed it. But that may just be, as you said, that may just be due to a lack of education about the product, or even just their availability.
Yeah.
As much as we get out there and try to promote ourselves and what we do, and alert people that there are other means than traditional medicine, that there are these alternatives. Sometimes it seems to fall on deaf ears or doesn't make it to the right ears.
Okay. Yeah. If we can get people to come to the conference, amazing, watch the live stream. But there is a lot of it. This year we had, I think there were about 30 hours of pre-recorded presentations, apart from the 2.5 days as well. It's quite a commitment to sit and watch them. I mean, you do have a year to watch the presentations, but 9 out of 10 prescribers that watch it are so enthused by it they will go and prescribe LDN. And of course, as soon as they see patients doing well, they want to prescribe it more and more. But it's
well, I think everyone has patients that they have that they're looking for something and they just can't seem to find that one, not magic bullet, but just something else that would help them that they hadn't thought of yet. And then sometimes they're like, oh, let us try this, as you said. And then they're like, oh, wow, that worked really well for, Miss Hill over there. Maybe we need it for, Miss Parker over here, or a different gentleman for a different condition. This may help them that they had thought of prior.
Exactly. And it's, an eureka moment, isn't it, when you've had a patient who's really ill and there's nothing else you can do and the patient isn't getting any better, and then discovering, LDN could possibly work and seeing what the results are. I find it really fascinating.
It's fascinating and satisfying at the same time that you're able to. I feel like that's what we got into the medicine, to help them out with these things, to make, to give them the treatment that they need to, help improve their lives that they have.
I mean, you said that you compound supplements as well. I mean, what would you say your recommendations to patients are who are taking LDN? What supplements would you say they should be taking or checking for?
Because a lot of that naltrexone seems to help with inflammatory disorders. So we usually recommend other anti-inflammatories to go with it. Kind of like some vitamin C's in there, like B6s, B12. Like we like our B complexes that we have. So just an overall energy boosting for patients, like our patients who have chronic fatigue syndrome or that may need that. We also recommend that they get their iron levels tested to make sure that it's not just a vitamin B issue, that it's actually, see if there's any iron component to it that's missing. that they don't have enough ferritin and things like that.
Mm-hmm. Why would somebody have low iron if they had a healthy diet?
They may not be getting enough iron from their natural diet. Like if they're not, like over here in the States, we have a lot of vegans or just vegetarians that if they don't consume enough beans or other means or even just iron supplements taken with in this acid forming, such as a citric acid or even just orange juice with it,
Mm-hmm.
they may not actually get enough absorption, and they might not be getting enough just in their diets, as I said, from lack of iron sources. Like they're not getting enough iron from beans or things like that.
How would you know if your absorption was working correctly?
You'd have to get a lab test from your doctor and then get a blood draw to see what the levels were. And they do move slowly, so you'd have to get a blood, like a retest after 6 to 8 weeks. Just if you were deficient, you had to get a test in 6 to 8 weeks to see if it brought it up or not. And then you can slowly continue to supplement from there. Because my own baby at 18 months he had a great diet. He drank milk. He did everything, but he still had an iron deficiency, which was surprising to us when we brought him to the doctor. But so we give him vitamin supplement, iron supplementation now for 3 months or so, and now his iron levels are back up to normal and have stayed. And we've been able to stop the supplementation. He's able to maintain his iron levels.
Oh, that's good. So you don't necessarily need to take it for life, just to increase it. Mm-hmm. Oh, that's good.
Just to correct it from the deficit that you did have.
Yes. Okay. So when a patient comes to see you, I mean, obviously you're not prescribers, but if you noticed there was something that could help a patient, how would you go about informing them?
Yeah, if we see a deficiency that we can help with a patient, we'll write them up in a note and tell them, like, this is what we recommend to your doctor. And then we ask if they want us to fax it over to them on their behalf, or if they want to bring it into their doctor, if they want to call their doctor about it. So we'd help educate them about what the issue is, why we think this is a good treatment for them, and why it's a good way to progress, and then present them with the way to get what we suggest that they should get.
Mm-hmm.
The most prescribers in our area they have worked with their patients for years or decades. So anything that a patient brings to them, they're most likely to let them try it because it has a sound rationale behind it, as opposed to saying a patient saying, "Hey, I found something on the internet and I think it'll work great."
And what do you think the response would be if you suggested for these chronic fatigue patients or MS patients LDN? Do you think the doctors would be open to that who haven't previously prescribed?
I do think doctors who have previously prescribed it may be skeptical about it at the beginning, but then they just want what's best for their patient. So if they don't have any negative experiences with low-dose naltrexone, in my history of my 10 years, I've never actually seen like any really severe allergic reactions. I've never seen any severe adverse effects from taking low-dose naltrexone. All I've seen that's bad was happen with someone who was on opiates before and got a medium dose of naltrexone, and then they went into withdrawal a little bit. But that was the only severe, slight case of anyone who's had an adverse reaction from our experience with it. So most doctors in that instance, when presented with a lot of positive that can occur to it and not a lot of negative, then they're more willing to prescribe it for their patient.
Mm-hmm. And what would you say the outcome has been of the patients that have tried LDN?
Yeah, I would say it's not all of our patients, unfortunately, that get benefits from it. It seems to really be about 6 out of 10 or 7 out of 10 patients who do take it and take it regularly, and take it at bedtime, take it the same rough time at bedtime, seem to have the best effects with it. But as medicine is, not all medicines work the exact same way for everybody, unfortunately.
Mm-hmm. What dose range do you compound?
The majority of our patients, we have a dose range of one. So we either do 1.5s, 2.1s, 3.1s, 3.5s, 4.5s. We have a few patients on 6, and we've done a few patients up to 9. But the majority are down in the 3 and 4.5 range.
Mm-hmm.
Because most of the studies and most of the tests and most of the studies that have been done on the 4.5 milligram variety of low dose naltrexone, as opposed to higher doses. And then we start the lower doses because people should be titrated up slowly, as opposed to just jumping to the highest dose.
And why I was saying about pain specialists is because pain specialists now are using ultra low dose LDN, which is 0.001. So it's, really micro dosing. And it seems to work absolutely amazingly by using this microdose alongside of the opioids, not taking them off, keeping them on, makes the opioids far more effective. And then they're able to decrease the opioids while increasing the microdose, and actually weaning people off the opioids that have been on opioids even 20 years. I heard the story the other day. Coming off the opioids on LDN and having better pain relief than they were on this cocktail of opioids, and didn't go through withdrawal. And now that is just amazing.
That's just amazing. It's fantastic, though, at the same time.
Yeah, we're doing a documentary on opioids and LDN, and we've interviewed several pain specialists who have amazing things to say. So we are hoping, for big things with LDN, and hopefully we will have to get you to make ultra low dose as well.
Excellent. Well, we look forward to that. I'll have to read more papers on that.
Yes. Yeah.
So I thought they had talked about pico dosing and nano dosing, and I was like, so it seems more like homeopathic sometimes at that point, where it's like, how small of a concentration can you have before you actually start to see an effect?
Mm-hmm. But
and that's fantastic. That doesn't have to be that high.
Yes,
and it doesn't cause any withdrawal effects.
I know.
It can be used simultaneously to help improve anti-inflammatory at the same time.
Yeah.
And not have to use such high doses of opiates.
Exactly. And the pain specialists that do use LDN at 1.5 will use it with opioids, but only several hours apart. So if you take one in the morning, you take the other one at night, like that. We don't ever recommend that anybody does that themselves, that it always has to be under medical supervision. But there are doctors that will do that and find that it does, work really well. But maybe it's the same thing as, the ultra low dose alongside of the opioid, making it that much more effective. But it's certainly something that is a hot topic at the moment, should I say, which is really interesting. So what's your next goal in your pharmacy?
Our next goal?
Yeah.
So currently we're rolling out our USP 800. We're working at the regulation part on that to improve us. And then we also have some creams out for testing now to help increase the BUD study, like the beyond use dating, that people can have for pregnenolone. Because right now there's no studies that pregnenolone is only good for 30 days based on USP 795. So we put them out to a testing lab, and we're on day 90 now. We've had good results so far. So we're pushing the boundaries there on science to see how long we can get pregnenolone in the space for, so that patients can, have larger day supplies and less frequent turnover of medication, like having to order it, and decreasing the burden on that.
So what is that actually for?
Oh, pregnenolone's part of the hormone replacement therapy creams. Okay. It helps synthesize other hormones for you. That's like a precursor.
So when people take hormone replacement medication, I mean, is that just one medication once a day, or do they have to take more?
Some prescribers use it once a day, and then some prescribers do it twice a day. It depends on the doctor and the prescriber. Some doctors who want to keep the levels up more sustained have found that to use the cream twice a day seems to be more effective than once a day. But then again, it goes back to being patient dependent, as some of their patients only use them once a day, and they seem perfectly happy with that. And sometimes it's just replacing progesterone that women lose over time, like people who are over 50 may have experienced progesterone loss. So then it's just bringing their progesterone levels back up to where they were originally. So we're just, then at that point, you're just supplementing the progesterone at bedtime, and that's it. Because it can cause drowsiness in some people as well. So you wouldn't want to be drowsy during the day. So the prescribers prescribe it in the morning.
And what about blood tests? Do they always come back showing that the tests are negative or positive even for thyroid problems, hormone problems? What I'm trying to ask is it a clear-cut thing where, this is the marker you've got, so you definitely need some help, or are there grey areas?
I would say there's black and gray areas where it's like, well, it depends what level they're looking for. Like people who have thyroid, some people just look at the thyroid stimulating hormone levels and base it off that, when they should really be using more of a direct T3 and T4 blood test. It's a little bit more expensive, obviously, but they use the direct T3 and T4 just to ensure that your body is converting the T4 into the active T3 and then back to the inactive T4. Because if it's not getting to the active state, then it'll look fine on your blood work. On just the thyroid stimulating hormone side, it'll look fine on your blood work, but then it won't be fine once you take the direct levels.
Because I
Similar
know
to testosterone.
I know that some people have had tests, gone to one doctor and had the tests and been told they're fine, then go to another doctor and have a different test and find they actually do need help.
But they always had this great line in college where it was like, are you treating the numbers or are you treating the patient? And so they would be looking at the symptoms that the patient's experiencing in regards to, are they losing weight? Are they having excessive sweating? Are they just gaining weight? Are they irritable? Are they, somnolent? Are they, are they too tired? Not tired enough? Too much energy? Not enough energy? And there's so many variations, especially for the thyroid patients, that they have to take into consideration.
But it's not helpful, is it, when you go to the doctor and feeling really unwell, to be told that your blood tests are normal? There's no further action that needs taking, but hang on, I don't feel very well. There is something wrong with me. And then, of course, some of these patients are then told it's all in your head. You're imagining it.
Yeah, there's that, unfortunately. That does occur. But yeah, like people always want to go. You have the people who don't even want to go to their doctors, but then they're like, well, I need an answer. I need to know what is wrong. And then after going to their doctor, they're like, my doctor said there's nothing wrong. Must not be anything wrong.
So what are you able? I was going to say, what are you able to do as a pharmacist if a patient comes to you and say, I've had these blood tests and they're all negative. There's nothing wrong with me yet. I'm really not well. How do you help those patients?
We would interview the patient at that point. We try to draw out of them what part of them's not feeling well, and then try to find what may have caused that from the start, like more of the history and the biography of what caused their unwellness, and then what things they've tried to for their unwellness, and then either possibly recommend a different doctor for them if they didn't go with a doctor who specializes in what seems to be wrong with them. Or maybe we may have to do, depending on what they say, we might have to do some further research with them to see what else we can find on their topic of what seems to be ailing them. Like things that we may not have even considered.
Yes. Yeah. Now, as I say, you're in New Jersey, so how far if you look at the whole state of New Jersey, whereabouts are you based?
We're about in the middle, against the shore. We're an hour and 15 minutes south of New York City, about an hour north of Atlantic City, and an hour and 15 minutes diagonal from Philadelphia. So we're right against the shore, about halfway up on the coast.
Right. Okay.
Yeah.
I've actually been to Atlantic City as well. I came back and I think I was home about a week, and they had those terrible storms or hurricane or something, and it ripped all the boardwalk up. But it was quite nice. I was saying to my family, I went here, I went there. It didn't look like that though. I think I would have been quite frightened if I'd been there when that happened. But I did see it.
Hurricane Sandy was not a nice hurricane.
Yeah.
I had lost power for a day or two. There's people out. The pharmacy I worked at the time didn't have power for a week.
Wow.
It was very traumatic. That was inland, like 10 miles, like 10, 15 miles. Like it was a very, like for all the trees it knocked down and all the damage it did, it wasn't just the ravaging shoreline, which it did that as well, burying houses and just destroying every house on the island pretty much was almost seemed to be knocked down at some point.
Goodness.
There's just so much damage on the island. But
wow.
But then we rebuild and it's better than it was before.
But you do have more extreme weather than we have here.
Occasionally. There's not, I've only had one hurricane since I've been here, and that's the one.
Okay. Well, that's not so bad then, is it?
We do get some torrential downpours. We do get some lightning and thunder. They always warn of tornadoes, but I've never seen one in this area.
Uh-huh.
But
doesn't
mean it won't happen.
But your position, how you're located, what area do you cover around your pharmacy? How far do people travel to come to you?
People seem to people travel up to 45 minutes to come to us, but we do mail we ship prescriptions, just compounded prescriptions. We do ship for free throughout the state because we're licensed in the whole state. So the doctors will fax over their prescriptions, or they'll call them in, and then we'll get them ready, and then we send them out to the patient. So they don't have to if they're over 45 minutes away, they don't have to travel here to get their prescription if they can't get it anywhere else.
Mm-hmm. And you're licensed in which states, did you say?
We're licensed in New Jersey, where we are. But we're licensed in 8 states, I believe.
Okay.
We're licensed in Arizona, Connecticut, Colorado, Ohio, Pennsylvania, New York, Florida, Maryland. Those are the ones that come to mind.
For putting you on the spot there. It's tricky to remember, isn't it? Wow. So do you think Philadelphia, didn't you say you're near Philadelphia?
What was that about Philadelphia?
Do you ship there, Pennsylvania?
Yes, we do ship to Pennsylvania. There's a children's hospital on the edge of Pennsylvania that we do a lot of compounds for. There's the Children's Hospital of Philadelphia, and we help take care of some of their patients.
Oh, okay. Well, we've just about come to the end. You've already given your contact details, and that will be on the video for people to see. So thank you very much for having been my guest today.
Well, thank you very much for having me. I look forward to seeing you guys when you come visit New Jersey.
Thank you. Jersey Shore Pharmacy is a fully licensed and accredited pharmacy in New Jersey, specialising in compounding formulations such as LDN, bioidentical hormone creams, omeprazole and pet medications. They strive to help everyone with their individual needs. Visit www.jerseyshore.pharmacy or call 609 660 1111, Monday to Friday 9am till 7pm, Saturdays 9am till 3pm. You can find them on Facebook. Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.